Glenn White Chua, and this is my lecture on pharmacology in the emergency care setting. This is prepared for YL7 of the Ateneo de Manila University, the School of Medicine and Public Health. For the purposes of this lecture, there will be two main emergency situations that we will be covering. Um, we will be focusing on the drugs that are involved in each of these emergency situations. Although we will be also tackling partly the algorithms by which these emergency situations are handled, we will be focusing more on the molecules. But feel free to pause this presentation at any time, or perhaps to browse it in your at your will for you to take advantage of the material provided. So let's jump right in. So one emergency situation that we are seeing more frequently for the past year uh, is rapid sequence intubation. This involves the installation of an airway through the mouth, through the upper airway tract, directly to the trachea. Uh, and this involves a precise sequence of activities and a precise series of medicines that will ensure that the artificial airway is installed correctly. But for the first part, we will be tackling mainly different emergency cardiovascular situations. So the first emergency cardiovascular situation that we will be uh, moving through is acute coronary syndrome. You see here the algorithm from the American Heart Association. I will not delve deeply into this. I will move through this quickly, and you will see that uh, in the first line of handling acute coronary syndromes at home or upon handling of an emergency management service, you provide the patient with aspirin, oxygen, and morphine as pain control. So these three drugs are the mainstay of acute coronary syndrome management. As long as the patient um, can access a healthcare facility, and an ECG has to be done because this will determine what kind of approach we will be having for the patient. Looking into the different types of acute coronary syndrome, we have an ST elevated MI, high risk unstable angina, or a non ST elevated MI, and we have low or intermediate risk coronary syndromes. Note that for high risk unstable angina or non STEMI, we have the following molecules included in its management. We have nitroglycerin, we have heparin, we have beta blockers, oral beta blockers, clopidogrel, and glycoprotein 2B3A inhibitor. So these molecules all work to improve blood flow, to dissolve clots, and to uh, reduce the burden of the heart. We won't be going into much detail for these as these molecules have been discussed in your cardio module and other modules thus far. But it is important for you to memorize that at this point, these are the drugs, the molecules involved in the management of acute coronary syndrome. And these are oxygen, acetylsalicylic acid, nitroglycerin or nitrates in general. You may be you may be more familiar with isosorbide mononitrate or isosorbide dinitrate. Those are nitrates. Pain control in the form of morphine. Since pain from acute coronary syndrome is mediated by the vagus nerve, we have to provide an opioid. And then we have fibrinolytic therapy and heparin, as well as beta blockers to improve cardiac function. Now, we move on to other situations involving emergent situations involving the heart. Uh, you will notice that the categorizations are based on the rhythm of the heart or on the pattern seen on the ECG. So, as long as the patient is breathing, has a heart rate, do an ECG. Do it as soon as possible. So, this is the algorithm for handling a patient with tachycardia with a pulse. See the ECG strip on the lower left portion. That is a typical strip of a patient with ventricular tachycardia. Note the molecules involved in the management of ventricular tachycardia. These are adenosine and the beta blocker. Beta blockers will not be discussed in depth for this lecture, but adenosine, we will see that shortly. Going further, we see here that in addition to adenosine, we are also going to be tackling amiodarone. And these two molecules are part of the handling of patients with tachycardia with a pulse. So, we see here adenosine and amiodarone. We focus first on adenosine. Adenosine is an antiarrhythmic mainly indicated for supraventricular tachycardias. And this molecule decreases the sinus node, the frequency of the firing of the sinus node. I will not be discussing the details of this drug too much. I will leave that to you to read through this material and through the supplementary materials provided. But understand that I will not be asking too much of the details, and I will be counting mainly your familiarity with the names of the drugs and the indications for which they can be used safely. So these are the pharmacokinetics parameters of adenosine. Pharmacodynamics, that's intravenous or intraosseous. There is material or literature lately supporting that for emergency situations, intravenous is still much preferred. These are the adverse effects associated with adenosine and some special considerations. In fact, recording a rhythm strip during administration of adenosine is not unique to adenosine. It's something that should be done in the emergency setting, if possible, with any of the drugs that is going to be provided. Because many of these drugs, in fact, all of them, work quite quickly, within minutes, and you will see a rapid response in the heart rate or in the cardiac function. So moving on to the next molecule, amiodarone. Amiodarone is an antiarrhythmic, a class 3 with a wide range of applicabilities. So it can be used for supraventricular tachycardia, ventricular tachycardia with a pulse, pulseless arrest in the case of ventricular fibrillation or pulseless VTAC. Note that amiodarone should not be used in individuals with polymorphic VTAC or torsado point, as it is associated with a prolonged QT interval, which is made worse by antiarrhythmics like amiodarone. Note that in the guideline or in the algorithm, amiodarone is used only after defibrillation and after first-line drugs like epinephrine and vasopressin. So it also slows down the sinus rate and prolongs the PR and QT intervals. The additional benefits or effects of amiodarone is mitigated by its non-competitive block of alpha and beta adrenergic receptors. So these are the pharmacokinetic parameters of amiodarone, the pharmacodynamics, and the adverse events. Note that amiodarone is contraindicated for those with sinus node dysfunction and those with a second degree or third degree AV block. Amiodarone has a long half-life and it has many drug interactions. So we have many tools for us to use to check whether the drug that the patient is taking can have interactions with amiodarone. Okay, so that's it for amiodarone. And those are the main two molecules that we will be discussing as part of the treatment of adult tachycardia in the emergency setting. Adult tachycardia with a pulse. Now we move on to the next emergency situation, which is adult bradycardia with a pulse. So this is the algorithm for managing a patient with bradycardia with a pulse. Note the ECG strip on the right midsection. That is a typical ECG of a person with a slow heart rate, typically around less than 50 beats per minute. And the molecules involved in the management of bradycardia is primarily atropine from Atropa belladonna. And if atropine is ineffective, we can consider dopamine or epinephrine. And those are the three drugs that we will be moving through as part of the management of acute bradycardia. So atropine, dopamine, and epinephrine. So for atropine, it is an anticholinergic. It is indicated for symptomatic bradycardia, and it has been used as an symptomatic treatment to treat the symptoms of organophosphate and carbamate poisoning. Um, as you may remember, atropine is a potent sympathetic stimulant. It stimulates the sympathetic nervous system. By blocking acetylcholine and other muscarinic agonists at the parasympathetic neuroeffector sites. So, by blocking the parasympathetic, it upregulates now the sympathetic effects. So, part of the sympathetic effect, increase of heart rate, increasing cardiac output, reduced saliva production, and dilation, pupillary dilation, which is one of the historic uses of the plant from which atropine was discovered. So these are the pharmacokinetic parameters of atropine. The pharmacodynamic parameters, it is still administered intravenously or intraosseously. And a list of its adverse effects. Note that a lot of these adverse effects are stemming from sympathetic stimulation, like the dry skin, the flushing, the the hypertension, a paradoxical hypotension, the tachycardia, the glaucoma. Note that angle closure glaucoma in a patient is a contraindication for using this drug. And so are pre-existing tachyarrhythmias and thyrotoxicosis, because you will push the patient to a thyroid storm if the patient is given a drug that will stimulate further sympathetic response, the sympathetic response. So, a special consideration, as usual, monitor the vital stats when you administer atropine. Um, Atropine has a special role in the sedation of children. It is used in children with bradycardia if they need to be intubated. All right, so it is important that um, uh, patients with a head injury, atropine use will dilate the pupils. So it can confuse you. You will not be sure if the injury, if the uneven pupils are due to atropine or due to an injury in the midbrain. So moving on to the next drug, dopamine. Dopamine is a catecholamine, a vasopressor, and an inotrope. It's naturally occurring, but for purposes in the emergency room, it is supplemented. So it is indicated for the management of cardiogenic shock and distributive shock. As a catecholamine, as a vasopressor, it stimulates both alpha and beta adrenergic receptors. So that can be quite confusing. There is an important rule to remember about dopamine, and it will be reinforced later. Higher doses will trigger alpha responses. Higher doses will trigger alpha adrenergic receptors. Okay. So in stimulating alpha adrenergic receptors, there's increased systemic vascular resistance. In contrast to your beta adrenergic receptors, they will decrease systemic vascular resistance. Note that for dopamine, the difference between the alpha response and the beta response is determined by the dose. The higher the dosage, you will trigger the alpha adrenergic response. These are the pharmacokinetic parameters of dopamine, the pharmacodynamic parameters, the adverse effects. Similar to other catecholamines, infiltration, local infiltration into the skin or areas without collateral circulation may result to local necrosis and gangrene. Special consideration, mixing with alkaline solutions can inactivate the drug. As I've said, it is important for you, for us, working in the emergency setting, to remember that dopamine is dose dependent. Low infusions usually stimulate dopaminergic and beta adrenergic receptors. Alpha adrenergic effects become more prominent as infusion rate is increased. A higher dose will trigger alpha adrenergic effects. So what are these alpha adrenergic effects that we are talking about? So alpha adrenergic effects are vasoconstriction, increased peripheral resistance, increased blood pressure, mydriasis, or a dilation of the pupils, and a closure of the bladder sphincters. Those are alpha adrenergic responses, specific for alpha 1 receptors. Now, beta adrenergic receptors, for beta 1, you will have an increased heart rate, increased lipolysis, increased myocardial contractility, and increased renin. Beta 2 adrenergic receptors, you have vasodilation, in direct opposite to alpha 1. You have decrease in peripheral resistance, again, in direct opposite to alpha 1. Bronchodilation, increased glycogenolysis, increased glucagon release, and relaxation of the uterine smooth muscle. Alright, so moving on. You may revisit this slide in your own time or browse the material provided to supplement this lecture. So moving on to epinephrine. Like dopamine, epinephrine is a catecholamine, a vasopressor, and an inotrope. It is indicated for anaphylaxis. EpiPens is the mainstay for children with severe allergies. So for children who are severely allergic, for example, to food or to strawberries or to peanuts, mainly in European settings or in the Western settings, I haven't really seen an EpiPen here in the Philippines unless they are brought in from abroad. EpiPens is life saving, which is why I find it weird that we still don't have them in the country. Anyway, EpiPens, epinephrine are indicated for anaphylaxis, asthma for immediate vasodilation, bradycardia, CRU, which is a relaxation of the airway, pulseless arrest, also another indication for epinephrine, shock. Clearly, shock needs to be treated with epinephrine. And toxins that may slow down or reduce the contractility of the heart. So what are the effects of epinephrine? It stimulates alpha adrenergic receptors. It also stimulates beta 1 adrenergic receptors and also stimulates beta 2 adrenergic receptors. Okay. But the overall effect that we see here is that there is an increase in the heart rate, a dominance of the bronchodilation, and a vasodilation of arterioles. So the net effect of epinephrine really is to get the heart running, to get the heart pumping. So these are the pharmacokinetic parameters of epinephrine and some of the adverse effects of epinephrine. I would like to pay attention particularly to hyperglycemia. Epinephrine can push blood sugar higher. It can trigger arrhythmias, particularly VTAC, and it can mask conditions because it will trigger an increase in lactate. So lactate dehydrogenase as an indicator of ischemia can be masked by epinephrine. Fortunately, we have other biomarkers to monitor in case of ischemia. Some precautions in using epinephrine. As with most catecholamines, it is inactivated in alkaline solutions. High doses produce vasoconstriction. Low dose may increase cardiac output with redirection to skeletal muscles. So there is also similarly a dose-dependent effect in epinephrine. Now, note that epinephrine is not recommended to be given subcutaneously in case of anaphylaxis. It is best delivered intramuscularly. Epinephrine for anaphylaxis intramuscularly. Otherwise, for cardioversion, for cardiac emergencies, it is best given IV. Okay, so those are the three main molecules involved in the management of adult bradycardia with a pulse. And then, for the moving on to the next cardiac emergency, cardiac arrest. So this is the algorithm for cardiac arrest based on the material of the American Heart Association. Note that there are two main categories of cardiac arrest. One is asystole or pulseless electrical activity, and we have, on the other hand, ventricular tachycardia or ventricular fibrillation. It is important to differentiate between VTAC, VFib versus asystole because in VFib or VTAC, you provide a shock immediately. Kailangan mo ng defibrillator agad-agad if you are seeing tachycardia, ventricular tachycardia, or ventricular fibrillation. Not drugs, you shock immediately. You give the shock first in ventricular tachycardia or in ventricular fibrillation. So the molecules involved in the management of these situations of asystole, pulseless electrical activity, ventricular tachycardia, or ventricular fibrillation, the first line is epinephrine. It is given after CPR and after shock. And only for ventricular tachycardia or ventricular fibrillation can you give amiodarone or lidocaine. So these are some of the details for the algorithm for cardiac arrest. Note that there are three main drugs involved. That's epinephrine, which is indicated for both VTAC, VFib, and asystole and PEA. And only for VFib and VTAC, amiodarone or lidocaine. All right. So VFib or pulseless VTAC, we have lidocaine. Lidocaine, as you may be familiar, is an anesthetic, but it is also an antiarrhythmic because of its blockade of the sodium channels. It is indicated for ventricular fibrillation and pulseless VTAC and tachycardia with a wide complex. So, it increases the electrical stimulation threshold of the ventricle and the bundle of His-Purkinje system. It reduces intracranial pressure through inhibition of sodium channels. This is one feature of um, of um, of lidocaine that will be useful in intubation, but we'll get to that later. So these are the pharmacokinetic parameters of lidocaine, the pharmacodynamic, the adverse effects for lidocaine. Okay, it can cause seizures in high concentrations, and as I said, high plasma concentration may cause myocardial and circulatory depression because it is an anesthetic. So that's the details for lidocaine. And the other drugs involved in the management of ventricular tachycardia or VFib, like amiodarone, has already been moved. We've moved through amiodarone earlier, and epinephrine. So those are the three main drugs involved in VTAC VFib management. Now, for the other type of cardiac arrest, which is asystole or pulseless electrical activity, we only have epinephrine. Also, we have discussed it previously. Now, so we have seen the molecules involved in the management of cardiac arrest. Again, I emphasize the difference in the handling of VTAC and VFib versus the handling of asystole. In both cases, you use epinephrine, but only in VTAC or VFib will you use amiodarone or lidocaine. Now, once you have successfully re-established a sinus rhythm in your patient, you can now move on to this algorithm wherein you are managing a patient post cardiac arrest. So make sure you help provide adequate oxygen, that the patient has adequate blood pressure. So you can give vasopressors or beta blockers depending on your situation. But the molecules involved, as usual, epinephrine and dopamine, or dopamine and norepinephrine. Another option that can be used in addition to dopamine or epinephrine is dobutamine. So the two molecules that will be discussed in the management of post-cardiac arrest individuals would be dobutamine and norepinephrine. We'll look first at dobutamine. Dobutamine is a catecholamine, a beta-adrenergic agent. Beta-adrenergic agent indicated for congestive heart failure and cardiogenic shock. So, it stimulates beta-1 receptors and stimulates beta-2 receptors. It both stimulates and inhibits alpha receptors. So, a net alpha receptor effect, 0. So, you have a net beta receptor effect, which increases heart rate and causes vasodilation and improved cardiac contraction. So, these are the pharmacokinetic parameters, the pharmacodynamic parameters. Also, this drug is given intravenously or intraosseously. A list of the adverse effects you see when you use dobutamine. Note that dobutamine can cause myelosuppression, neutropenia, and anemia. It can also cause premature ventricular contraction. As with other catecholamines, it can be inactivated if mixed with an alkaline solution. And like other catecholamines, extravasation into tissues that have poor collateral circulation can cause tissue ischemia and necrosis. The other drug that can be used in the management of patients post-cardiac arrest is norepinephrine. It is an inotrope, a vasopressor, and catecholamine. You will be familiar with norepinephrine since it is the other molecule aside from epinephrine that is driving the adrenergic response in the body. So, you have norepinephrine indicated for hypotension, usually distributive shock. So it is indicated, it is used because of its alpha adrenergic effects. It increases smooth muscle tone, but it also activates the myocardial beta-1 adrenergic receptors. So medyo templado yung effect ng norepinephrine, mas malumanay. It will improve contractility of the heart, and at the same time it will also improve the movement of blood through the systemic circulation. These are the pharmacokinetic parameters of norepinephrine, the pharmacodynamic parameters of norepinephrine, and the adverse effects. As with other catecholamines, similar inactivation by alkali and tissue necrosis or ischemia due to its vasoconstrictive effects if there is local extravasation. Alright, so those are the molecules involved in cardiac arrest. Please feel free to go browse through the material in your own time for you to read more about the molecules. So that's the overview of the molecules involved in emergency management of cardiovascular situations. So at this point, we will be talking at two, two more molecules that have use not just in a cardiovascular event, but overall is useful both in the emergency room and in the management of patients with various health conditions. Sodium bicarbonate, a very popular alkali and an electrolyte, is indicated for the management of metabolic acidosis, hyperkalemia, and sodium channel blocker overdose, specifically lidocaine. Lidocaine. All right. So, sodium bicarbonate increases plasma bicarbonate, so it buffers your protons or H plus ions. It's important that when you use sodium bicarbonate, you are in a well ventilated area or you are providing adequate ventilation to the patient, adequate oxygen because they will produce carbon dioxide. Pharmacokinetics, pharmacodynamics of sodium bicarbonate, a listing of the adverse effects of sodium bicarbonate. Note that, of course, sodium bicarbonate will cause hypernatremia. It can cause formation of kidney stones. It can cause respiratory depression because of alkalosis. All right. And as I've said, it's important that your sodium bicarbonate is when you use it, you provide adequate ventilation because your patient will produce a lot of carbon dioxide as the sodium bicarbonate reacts with acid in the body. It may inactivate catecholamines, as been repeatedly emphasized, so don't mix it in solution with your catecholamines like your epinephrine, dopamine, norepinephrine, and so on. So when combined with calcium salts, it can produce crystals and may precipitate into insoluble calcium carbonate crystals. So that can block your catheters, your tubings. So that is something to consider. Another molecule that has wide application in the emergency setting is furosemide, a diuretic. This is a loop diuretic and is primarily indicated for pulmonary edema or fluid overload. It acts on the ascending limb of the loop of Henle, inhibiting reabsorption of sodium and chloride. So, where sodium goes, water follows. If you do not reabsorb water, if you do not reabsorb sodium, you will not reabsorb water very well. Unfortunately, when you use furosemide, you also excrete potassium significantly. And that is one of the reasons why one of the leading adverse effects of furosemide is hypokalemia. Also, you also have a decrease in the serum concentration of your other electrolytes like chloride and magnesium and sodium and calcium. High furosemide can cause metabolic alkalosis because of the loss of electrolytes. And it's important to know that furosemide can cause Stevens-Johnson syndrome, SJS. Okay, so those are some of the important molecules involved in the management of cardiovascular emergencies and some others. Now we move on to an interesting situation being done now in emergency rooms across the world, and that is intubation. It is recommended to have a low threshold for intubation with the following indications. The patient manifests with rapid progression of oxygen requirement over hours, meaning hindi nag-improve ang oxygen saturation levels even if you are providing more and more oxygen. There is a lack of improvement on more than 50 liter per minute of high flow oxygen and the fraction of inspired oxygen at 60% or zero point 0.6 at least. There is evolving hypercapnia, increasing work of breathing, increasing tidal volume, worsening mental status. For you to properly assess hypercapnia, you need to be able to do acid ABGs, blood gases, acid and blood gases. Um, and also keep an eye out for hemodynamic instability or multi-organ failure. The moment that your patient manifests with a change in sensorium and a sign that your patient is not getting enough oxygen, less than 90, um, kahit na siguro mga 85, 84, mag-ready na kayo mag-intubate kasi doon na siya papunta. So, the first step in intubation is pre-treatment. What is the purpose of pre-treatment? The purpose of pre-treatment is to anticipate the effects of the drugs that you will be giving and the effects of the manipulation of the maneuvers that you will do. There are two main physiologic events that can happen in intubation. One is the pressor response, and the other is intracranial hypertension. Both of these are actually part of the sympathetic response, or perhaps part of the reflexes that are protecting the upper airway. So, what is the pressor response? There is a transient increase in blood pressure and heart rate due to upper airway manipulation. Intracranial hypertension is possibly stimulated by the gag and cough reflexes. So either way, both the pressor response and intracranial hypertension are related to the body's default response to keeping the upper airways open. And so we need to give medication to make sure that these physiologic events are not very disruptive or will not cause further harm to the patient. So what are the important molecules involved? Oxygen, fentanyl, and lidocaine. So for oxygen, it's important for us to pre-oxygenate. Meaning, you preload oxygen. Lagyan nyo na ng madaming oxygen yung katawan because you will not be providing oxygen in the window that you are inserting a tube into the airway. Pre-oxygenation before induction and paralysis allows up to 8 minutes of apnea time, up to 8 minutes in healthy adults, before arterial oxygen desaturation below 90% occurs. So, typically 3 to 5 minutes at normal respiration. However, 4 to 8 large tidal volume breaths can substitute in urgent situations. Essentially, kailangan mo talagang pataasin yung O2 sat ng patient bago ka mag-intubate. But in many cases, hindi mo talaga mapapataas yung O2 sat ng patient kahit bigyan mo siya ng pinakamataas na level ng flow, kahit yung pinakamataas na FiO2. So, regardless, may pre-oxygenation or hindi, you intubate. But if it's possible, pre-oxygenate. Now we move on to fentanyl. Fentanyl is indicated for elevated intracranial pressure for people with cardiovascular disease like ischemic coronary disease, aneurysmal disease, great vessel rupture. Essentially, you want to suppress the cough or gag reflex with lidocaine. So it's administered intravenously and has a quick onset of around 1 to 3 minutes. It helps decrease catecholamine discharge secondary to intubation. So, fentanyl disrupts the cough and gag reflex. That cuts down the risk of increasing intracranial pressure and bursting your fragile blood vessels. Now, lidocaine. So this is lidocaine now. It is indicated for those with head injury, traumatic brain injury, and those with elevated intracranial pressure. It's also administered intravenously, although it can be administered orally as well. Lidocaine will help protect the patient from increases in intracranial pressure caused by intubation. So these drugs, oxygen, fentanyl, lidocaine, can be given in combination or in sequence. It's not very particular, but the protocol changes depending on your patient situation. So for increased intracranial pressure, it's important for you to use one of these sedatives or of these pain control agents, fentanyl or lidocaine. Pre-oxygenation as much as possible is recommended. Now, induction or sedation. The goal is to induce rapid loss of consciousness with minimal impact on the blood pressure, on the breathing, and the pressure, intracranial pressure. Now, I emphasize that paralysis, which is the next step, paralysis without sedation is inhumane. Paralysis without sedation is inhumane. Without sedation, you are inducing paralysis with the patient awake and conscious. Alam niya na hindi siya makagalaw. Alam niya na hindi siya makahinga. Alam niya na hindi niya kontrolado yung katawan niya. So, we put the patient to sleep before we paralyze them for rapid sequence induction. So what are the agents involved in sedation? Etomidate, ketamine, propofol, and not a popular option, midazolam. So we focus first on etomidate. It is used almost in all patients for emergency rapid sequence intubation. You may use another agent if the patient is septic, infection, or in status epilepticus. So some adverse effects associated to it with etomidate is myoclonic activity, some seizures, inhibition of cortisol synthesis, adrenal insufficiency, pain and injection. So if the patient is having sepsis or somewhere in the spectrum of sepsis, inform the care team that you have used or will be using etomidate. So generally, etomidate is widely indicated widely for almost all patients. Now, another choice for sedation is ketamine. Ketamine is a controlled drug in the Philippines, but it is a good option for patients in the US and Europe with reactive airway disease or who are hypovolemic. Some side effects include increased secretions, emergence reactions, hallucinations. One of the benefits of ketamine is, well, anamnesic, or how do I say this, hindi naaalala ng pasyente kung anong nangyari sa kanya. Yun ang one of the advantages of ketamine. Hindi naaalala ng pasyente. It is not recommended for patients with hypertension or with normal blood pressure. Use with caution in patients with cardiovascular disease. So that's it for ketamine. Propofol. Propofol is indicated for hemodynamically stable patients with reactive airway disease or inactive seizure. So, it can cause hypotension, myocardial depression, reduced cerebral perfusion, reduced intracranial pressure. It is ultra short acting, but these negative effects limit its use for rapid sequence induction. But it is still useful for patients with who are having active seizures or reactive airway disease. And the unpopular option but is still used in specific situations is midazolam. Not routinely recommended for rapid sequence intubation, you may opt to use it for post-intubation management. Side effect is hypotension, respiratory depression. It is a benzodiazepine as sedative. It can cause apnea. It is not recommended for RSI. Inuulit ko, not recommended for RSI. And the response may be extremely variable. So, the last step before you insert the tube through the mouth, through the larynx, into the trachea is paralysis. And paralysis is done through neuromuscular blockade with either depolarizing or non-depolarizing agents. Kapag hindi nakakagalaw yung pasyente, hindi siya masyado mag-a-agit, hindi niya tatanggalin yung tubo, hindi niya isusukan ng basta-basta yung tubo, you are not going to combat the gag and the cough reflexes if you induce paralysis. So a certain practice involves defasciculation with a non-depolarizing relaxant prior to paralysis. Usually ginagawa to doon sa pre-treatment phase, yung defasciculation. It is usually not recommended for rapid sequence intubation. Defasciculation as part of pre-treatment is not recommended for rapid sequence intubation. Expertise is needed for use in elective settings. So, the molecules mainly involved in paralysis are succinylcholine and rocuronium. Rocuronium has many relatives: pancuronium, vecuronium. These are molecules derived from the skin of your poison dart frogs. So, succinylcholine, it is a depolarizing neuromuscular agent. In fact, it is the only depolarizing neuromuscular blocking agent. It is indicated for essentially all patients except for those with malignant hyperthermia or a history of malignant hyperthermia and or hyperkalemia, meaning those with massive cellular injuries or massive bodily injuries. So burns, more than 5 days after burns, may crushing injuries, denervation, severe infections. Those people have lots and lots of cells dying, and with those cells dying, a lot of potassium is floating in the extracellular space because they are not trapped within cells. So, massive cellular death is more or less a condition leading to hyperkalemia. You don't want succinylcholine for them. So, intracranial hypertension and penetrating eye injuries are also not indicated for use of succinylcholine. So, succinylcholine is given intravenously, and adverse effects, we have a long list here: tachycardia, bradycardia, malignant hyperthermia, masseter muscle rigidity, which is a parang a foreshadowing of malignant hyperthermia. Bradycardia may occur after repeated doses. What is this pharmacologic event? Paradoxical effect after repeated doses. Anyway, have atropine ready in the event should it occur. Rocuronium and its relatives, vecuronium, pancuronium. Well, but we'll talk about rocuronium specifically. Rocuronium is a non-depolarizing neuromuscular blocking agent. It is indicated when succinylcholine is contraindicated. But it is widely used now, at least in the medical city and more and other hospitals. Rocuronium has a much longer duration of action than succinylcholine by up to 2 hours ang duration ng effect ng rocuronium. But there are no clinically significant adverse effects associated to rocuronium. No clinically significant adverse effects associated to rocuronium. And you know what? What makes rocuronium even more attractive as a paralytic agent is sugamadex. What is sugamadex? Sugamadex is a carbohydrate, and it's also essentially parang an antidote, a blocking agent of rocuronium. It reverses the effects of rocuronium. So, when you do not want the paralysis of rocuronium to persist, magbigay ka na ng sugamadex. So, rocuronium paralyzed for up to 2 hours, na-insert mo na yung tube, okay, gusto ko na gumagalaw yung patient para makahinga siya ng mas maayos. Bigay ka na ng sugamadex kung sumobra ka ng rocuronium. Diba? Parang may instant off switch in case you need rocuronium effects, in case you need the paralysis to be reversed immediately. That's adding to the attractiveness of rocuronium as a paralytic, as a neuromuscular blockade agent, because there is an agent like sugamadex that reverses it quickly. Alright, so one last thing for sugamadex, it does not inhibit acetylcholinesterase like your traditional agents like neostigmine. Okay. Alright. So, these are the molecules involved in the paralysis, in inducing paralysis as part of the rapid sequence intubation. So, let me run it down. The molecules involved for rapid sequence intubation, as pre-treatment, you have oxygen, fentanyl, and lidocaine. For induction or sedation, you have etomidate, ketamine, and propofol. And for paralysis, you have succinylcholine and rocuronium. Alright, so those are the molecules for rapid sequence intubation. And that's it. That's the overview of pharmacology in the emergency care setting. You will be encountering a lot more drugs in the emergency room. And I encourage you to strongly encourage you to read through this material, revisit it, pause it, go back, go forward, fly through this material at your own pace. Read the materials that will be provided along with this lecture. So, that's it. Thank you very much. That's me, Peter Glenn White Chua, and this is my lecture, Pharmacology in the Emergency Care Setting. Thank you very much.